attending the fourth session, and thank you so much for your perseverance and taking your time for learning how to make evidence-based decision, whether it's in the research or in clinical practice. We found in the first session the importance in defining a clear question, and in the second session we found how to make a clear question. And in previous session that we had a good lecture from Professor Khami and Professor Shamshiri. We found that it was informed that how to search for evidence-based resources, how to search medical subject heading, mesh term, as you know it, to find a particular aspect of the subject, and your research query finds articles with the mesh heading. And today you will find how to critically appraise those articles and the information you have found. It's very important in different databases and different search engines. As you know, today's lecture is Professor Khami and Professor Shamshiri. Like the previous session, I would like to welcome Professor Khami and welcome Professor Shamshiri for attending for this session and your lecture. And as you know, we'll have a live question and answer at the end. And also during the lecture, you can write your question in the chat box. At the end, it will be answered. Okay, Professor Khami, the stage is yours, please.
Thank you, Dr. Mutawassilian. In the name of God, the compassionate and merciful. Okay, so this is our fourth session of this virtual evidence-based dentistry course. I would like to thank you all again for being participants of this course. I hope today we can proceed well and we can cover the topics that we want to do. First, I start with the title of types of epidemiologic studies, and then my dear colleague Dr. Shamshiri will continue. So still we have 2 minutes for to start our session, because we want to start at 2 o'clock in Tehran time. Now we have 18, 19 participants, and maybe after a while we will have some more. So just before starting, I want to say that according to the spiral design that we have for this course, and the fact that we don't know the level of knowledge among participants, so in my first presentation, I will start from the very basic concepts of epidemiology, and then we will continue to more deep layers, and especially regarding systematic reviews and randomized controlled trials. We will have some more topics to be covered in our next sessions, because these 2 types of studies are really important in evidence-based approach. But in my first lecture, I will review briefly the other types of epidemiological studies, and then we'll continue with some points regarding critical appraisal of these types of studies, because the core of evidence-based dentistry approach is the ability to do critical appraisal. It requires to have a critical thinking approach. So it seems crucial for all who wants to practice evidence-based approach to have some insight to epidemiological studies and how to critically appraise these studies and articles. Okay, so I think now we can start. Okay, I hope you can see my slides, my presentation. Maybe, oh, I should, okay. Can you see? Do you have my presentation? Just to be sure.
Yes, doctor, we have your slide.
Okay, thank you. So today we want to first start with the classification of epidemiological studies. And in this presentation, I'll try to cover these topics: basis of epidemiology, definition of epidemiology, purposes of epidemiologic studies, the types of epidemiologic studies, then something about descriptive epidemiology, and then regarding interventional studies. And at the end, we will take a look at the hierarchy of evidences. There is a sentence, a really important sentence, which is truly the basis of epidemiology. And the sentence is this: occurrence of disease is not random. So this is the basis of epidemiology. All other things in the science and discipline of epidemiology is constructed around this base and around this core. So when the occurrence of disease is not random, this means that there are some factors that shaping and creating and developing and changing the occurrence of a disease, of disease in the community and in the people, and as well as in individuals. So these factors can be classified and can be categorized as who, when, where, why. So in epidemiology, we are trying to find the answer of these questions: who, when, where, and why. And of course, some other questions, but these are the main questions. In epidemiology, we try to find what are the risk factors, how they act, how much important is their role, why these risk factors have a role, where they apply and implement their roles, and when. Okay, so according to this core of epidemiology concept, then we can say that the epidemiology, as a part of public health science, is a study of distribution, determinants, and frequency of disease or health conditions in population. This can be considered, can be just as maybe a simple definition of epidemiology. So the goal of epidemiological sciences and epidemiology is to control health problems of populations. Again, if we have a public health orientation. And I want just to name my dear Professor Mira Vehkalahti from University of Helsinki. I learned these basic concepts in her presentation when I was a PhD student, and I learned a lot from her regarding these basic concepts of epidemiology. So what are the purposes of epidemiologic studies according to what we said? Now we can say that we are trying to describe distribution of disease, to describe demographic variation of disease, to detect factors related to disease, to describe distribution of determinants of the disease. And then sometimes we want to test hypotheses on causal relation of disease, causal relations of disease, and then to evaluate effect of intervention on disease. So we can say that epidemiology is the most important discipline from preventive point of view, because if we know and if we can describe these factors and these distributions and these variations, then we are able to have some tools, to have some interventions to prevent disease. And we can from preventive aspect, we can do an important job using epidemiology as a tool and as a means. So we have disease and then we have risk factor. Sometimes we call disease outcome and sometimes we call risk factor exposure. So exposure disease, risk factor disease, risk factor outcome. These all of the epidemiological sciences and analyses are around finding the relationships, associations, and sometimes causal relationship between these two, risk factor disease or exposure outcome. We usually use exposure with outcome and risk factor with disease, and we know that we have now the web of causation for each disease. So the disease, most of the diseases are multifactorial. So there are many factors that affect incidence and prevalence of the disease. And we try to find how these different exposures or risk factors are related to each other at various levels. Then, if we come to the types and a kind of classification of epidemiologic studies, this is one classification, and I have another one in the next slide. So this shows that there are various classifications of epidemiologic studies. So this is, for example, one, and in the next slide I have another one. So in this slide and in this classification, you can see that we can classify epidemiological studies into three main categories: descriptive, observational, and experimental studies. So in descriptive epidemiology, we are just trying to work on and focus on disease statistics. How much is prevalent in various age groups, in various in the two genders, for example, in various geographical locations. So we just described. So the name is descriptive epidemiology. But in observational types of epidemiologic studies, you can see here we can three main categories again: cross-sectional studies, then retrospective studies, and then prospective studies. So I will explain about these three terms in the next slide because I personally prefer the next classification. Then in experimental studies, we can talk about clinical trials and community trials. We'll go to the next slide. As I told, I prefer this one because it's more comprehensive and more understandable in my mind. Here we have two types, two main categories: descriptive and analytical studies. So, and in descriptive studies, we have three main types of correlational studies: case report and case series, and cross-sectional surveys. It is said that case report and case series, some people prefer not to call case report as a specific type of epidemiologic study, but just a type of article. But sometimes, and in some people believe in that we should name them as studies. So we have these three categories in descriptive epidemiology, and then in analytical studies we have observational studies. So the analytical studies can be divided into two categories: observational and then interventional studies. And in the category of observational studies, now we have cross-sectional studies, case control studies, and cohort studies. You can see, and the cohort studies can be retrospective, or not just cohort studies, but in case control, in cohort studies. When I come to each of these studies, I will explain about these retrospective or prospective aspects. But just we can say that in cohort studies, we can have, we can use these two terms, but it is not a real retrospective. The real retrospective study is a case control study. I will explain about that. You can see here both cross-sectional surveys here and also here. This is because in cross-sectional studies, sometimes we just want to describe the phenomenon, the disease. the pattern, the condition. So it is just without any analysis. So it can be put here under the subheading of descriptive. But sometimes in cross-sectional studies, we also have some analysis. We do have some analysis in sometimes. So because of this, now you can see that cross-sectional studies can be categorized under both subheadings, both descriptive and analytical studies. And then interventional studies, we will talk more about this, specifically clinical trials in my second part of presentations today. Okay, so regarding descriptive epidemiology, it is useful in providing clues about disease causation and prevention that may be investigated further. So through descriptive, describing phenomenon and patterns and diseases, we will have some triggers in our mind, and then we can design another study to go deeply to the hypothesis that we have developed. They are useful in assessing health status in population. Sometimes just the statistics are important for us. We want to know, for example, how is coverage of, for example, dental services across the community. We need to have some statistics to know the coverage of our healthcare services, for example. So, and also sometimes regarding the health status of individuals in the community. These descriptive studies are also useful in allocating resources efficiently, because we all know that resources are scarce and we should be able to allocate resources as efficiently as possible. So this descriptive epidemiology is useful also in allocating resources efficiently. Then another goal of these descriptive studies can be targeting population for preventive programs. When you have some picture of your community through doing a descriptive study, then you are able to target your population. You will know that which section, which part of your community is in need for prevention, for treatment, for various levels of treatments. And this is really helpful when you want to have some program planning regarding health issues and healthcare service programs. Then usually in descriptive epidemiology, we are talking about disease frequency or rate by demographic factors like age, gender, race. So it goes back to the question of who, or the place of residence, going back to the question of where, time of disease, it is regarding when, and the level of education, who, but in detail, and the level of income, for example, who in detail, and many other demographic variables and factors that according to the disease we are studying, we can include in our study. So, for example, the seasonal variation in disease frequency is an example of when questions. So the time scales can be from decades to days. So the first type of these descriptive epidemiologic studies is correlational studies, or sometimes it is called ecological studies. So in the correlational studies, the data sources are from entire population to compare disease frequencies, either in different groups at the same time or in the same population at different times. So you can see here two examples of these correlational studies. They are sometimes can provide good insights into the pattern of the disease and risk factors in the community. You can see two examples: per capita use of sugar in various countries vs mean DMFT of 12-year-olds. So we just look at the whole data from the whole country, not to go in details and for example in each district or in each provinces, just the whole data from the country, and countries. The other example is, for example, dentist population ratio in various countries vs mean DMFT of 12-year-olds. And you can have some more examples, but just to show how these correlational studies are. And then regarding the case report and case series, a case report can arise suspicion of cause of disease. For example, you can also here again can see two examples: pulmonary embolism in a 40-year-old woman after 5 weeks of contraceptives in 1961. For example, it has been reported and has led to some specific kinds of disease and risk factors. And a more famous example is the second one: clustering and accumulation of cases is case series. And the famous example is 5 cases of young, previously healthy men with a rare type of pneumonia in 1980 and 1981. This led to the discovery of this HIV infection leading to AIDS. So you can see how they can be helpful in finding new diseases and finding new risk factors. Regarding the cross-sectional studies, there are 2 important points. Disease and exposure, as you know, are assessed at the same time. And valid association can be shown for those factors remaining the same over time, for example, gender, or for example, the age, which has a predictable trend. So the first point is very important. Disease and exposure are assessed at the same time. Because they are assessed at the same time, in many cases, we don't know which of them comes first, disease or exposure. Because of that, we cannot claim causal relationship from these studies. This is the important difference of these cross-sectional studies with cohort and mainly with cohort studies. I'll talk about that. And because of this, the level of validity in evidence-based approach is not very high. We will have a picture of evidence ladder at the end of this presentation, and you will see that what is the position of cross-sectional studies in the hierarchy of evidences. When we want to report these cross-sectional studies, I sometimes see in the articles that the terms causation is used, or the term effect is used, or the term affect is used. This is not true. We just can use the terms of association and relations when we are reporting the results of a cross-sectional studies. So we cannot say that according to cross-sectional studies that this risk factor had affected or had some effects on the disease, because we don't know which of the disease or exposure comes first, because we are assessing them at the same time. But we can say that this disease was this risk factor was in association with this disease. Okay. Then regarding case control studies, there are certain differences between case control studies and cohort studies. In the case control studies, the disease is the starting point of the observation. So we have 2 groups, group of cases and group of controls. The group of cases are diseased individuals. So in the cases group, diseased individuals are enrolled. But in the control, we have non-diseased. So the categorization and classification is based on the presence or disease. not the exposure. This is the difference with cohort studies. So based on this, so we have two groups, and then we go back to the, in the time to see, for example, in the case group, how many of individuals in the case group, they had some risk factors, specific risk factors previously. And how many individuals in control groups did have that risk factor previously. And then we will do our analysis and make some conclusions. This type of study, it is we can call it retrospective. Why we can call it retrospective? Because we go back to the time. We go back in the time to know how was the risk factors, okay? But and so this kind of studies, I mean, this kind of observational studies, which is case controls, is good for rare disease and common exposures. And of course, there are some problems, for example, with these studies. For example, when we go back to the time, we always have the problem of recalling information or getting information from, for example, previous records and files. Sometimes they are not complete, so we cannot have the whole picture that we want. So these are the problems when we go back to in the time. But in the cohort studies, in the next slide, I will show you these problems are less. Then the multiple exposures possible. We can investigate multiple exposures in these types of studies. I mean, case control studies. And then regarding cohort studies. Regarding cohort studies, as I told you, in cohort studies, we have two designs of retrospective and prospective studies. The retrospective cohort studies sometimes are called historical cohort studies. So if you hear historical cohort study, it is in fact retrospective cohort study. So the point is that in cohort study, we go to the future. The direction is to the future. The direction regarding time is to the future in both retrospective and prospective. But the starting point in retrospective cohort is in the past, but in prospective cohorts is in the present. But the direction is the same. So in retrospective cohorts, we come from a point in the past. We come to the present. And in prospective cohort studies, we start from now at present, and we go to the future, okay? So the difference with case control studies is that here, exposure is the starting point for subjects' enrollment to a study. So we classify, and we have two groups here, for example, or sometimes more than two groups. But the difference between these groups is just the exposure. So in all other, we try to have cohort studies like this, that the groups are the same, but just they are differing in the exposure. The exposure is the starting point for subjects' enrollment to a study. So you can now understand why cohort studies can provide us with more valid and more valuable information and knowledge, because we start, for example, in prospective cohort, we start from here and we follow our subjects, and we see and we observe what happens to them in the future. But for example, in case control studies, as I told you, the starting point is we go to past. So it cannot provide valuable information like cohort studies. So in the evidence ladder, cohort studies position is below. Case control studies position is below cohort studies. And these cohort studies are good for common diseases and rare exposures. You can see if we just going back to the previous slide, the case control studies was good for rare disease and common exposures, and the difference and the enrollment was based on disease. And here it is for common cohort studies is for common diseases and rare exposures, and the starting point is from exposure. So we will have 2 or more groups and then investigate the future change in the pattern of the disease in these various groups, which are different just in exposures. Then a couple of words about interventional studies. We have experimental clinical trials. So clinical trials are in this category. In all of the previous types of DS studies, we didn't have any intervention. We just observe. We were just observer in cross-sectional, in case control studies, in cohort studies. We were just observers. But in interventional studies, as their name shows, we are doing some interventions. We are doing some experiments. So according to 2 factors and 2 points, we can divide interventional studies in 2 categories. These 2 are randomization and control group. So if we have randomization and if we have control group, then we have a complete interventional or experimental studies. But if we don't have randomization or we don't have control group, then the name of the study would be quasi-experimental. So according to randomization and control group, we can divide these types of studies to experimental or quasi-experimental. You have seen about before-after studies. They are here as quasi-experimental because in before-after studies, we don't have any control group. So the example, the classic example is that, for example, you have a group of patients and you just give some, for example, drugs, medications to them, and then you investigate how many of them will be cured. This is classical before-after studies, and you can understand that, for example, it's the number of patients who are cured, who get well. It might not be related to the drug that we have prescribed because we don't have any control group. And anything that endanger your randomization, again, put your study in the category of quasi-experimental studies. One of other features in the interventional studies is blinding. And when we have blinding, it means that, for example, the patients do not know if they are receiving the real, the true, for example, medication or the placebo. So they are blind. If the individual who is giving this, for example, medications to them is also blind, and he or she doesn't know if this drug is the true one or is the placebo, then it is double blind. And if the person, an individual who is doing the analysis, does not know which group is the control and which group is the study group or intervention group, then it is triple blind. And you know that the results of these interventional studies are more reliable evidences. We can say that the science is the result of these kinds of studies, because all the factors in these interventional and in the most advanced type of these studies is randomized controlled trials. You have seen about these types of studies, randomized controlled trials. So you have both randomization and also the control group. These are randomized controlled trials. Science is the result of these types of studies. So at the end of this presentation, just taking a look at the evidence ladder or the evidence hierarchy. We will talk about systematic reviews. Systematic reviews are in the top of evidence hierarchy. The reviews are not original studies, but they are reviews, and the systematic review, because of its a specific design, so it is in the top level of hierarchy of evidences. It provides the high and the most valid evidences. So a well-done systematic review of 2 or more randomized controlled trials is in the top. Then we come to a randomized controlled trial in the second step. But we know that both of these types of studies are expensive, time-consuming, and difficult to run. Then we come to the cohort studies. So you can see cohort studies are higher than case control studies. And a dramatic uncontrolled experiment, although it is experiment, an intervention, but it is lower than case controlled studies, which is just an observational study. And then we come to reports of expert committees and opinions of respected authorities. And then we come to this, someone once told me. And unfortunately, the majority of today's clinical practice is based on the last 3 types of studies, these 3 types of studies. Here we have a more detailed evidence ladder. And you can see again, high quality systematic reviews are in the top. Then we come to large randomized trials with clear-cut results, certain results. Then we come to small randomized trials with uncertain results. For example, positive trends without statistical significance. Then we come to non-randomized trials with contemporary controls. So although they are non-randomized, but they have controls in the study. Contemporarily. And then we have non-randomized trials with historical controls, not at the same time. So the control group is not investigated at the same time as the intervention group. These are historical controls. Then we'll come to cohort studies, then case control studies, then dramatic results from uncontrolled studies. For example, an example is the treatment of infection with penicillin in the 1940s. Then case series and other descriptive studies, they are here. And report of expert committees and opinions of respected authorities. And the last level is, and the last and the least level here is based on clinical experience. The definition of evidence-based dentistry, if you remember, we told that clinical expertise is one of the 3 main dimensions. But when we are talking about the evidence ladder, clinical experience, value of evidence is in the last step. Okay, so thank you for listening to this my presentation. It was just a brief overview of epidemiologic studies. All of these types of the studies, they have many stories, they have many things, they have many important points, they have many details if you want to cover, but we cannot cover all of them in our course, but just to have some insight to the epidemiological studies. Thank you very much. Dr. Mutawassilian.
Thank you, Professor Khami, for your absolutely great presentation. It was full of information. I have many questions, but first I want to ask you to kindly answer one of the questions of our participant. The question was that what is the difference in the cross-sectional study and cross-sectional survey? Would you kindly please explain about this question?
Okay, I just give my answer, but maybe Dr. Shamshiri can complete if I'm wrong, or it can be my answer can be completed. When we are
Okay.
talking when we are talking about surveys, the descriptive aspects of the studies seems to be dominant. But when we are talking about a study, maybe the analytical aspect of the study can be dominant, because in cross-sectional studies, as I told, we can do some analysis. This is the answer I can say, but maybe Dr. Shamshiri can complete that.
Okay. And may I ask some of the questions that I have?
Okay, thank you.
Thank you. During your presentation, you informed that the prospective and retrospective studies, there is no intervention. Is it? There is no intervention, but we do something in order to follow the patient, for example, in the future time, or look at the experiment in the previous time. So at least some intervention existed before, or will be existed.
Okay, these kinds of activities cannot be considered as intervention. When we are talking about intervention, we are talking about working on the risk factors, modifying, changing the risk factors. If we are changing or modifying or even creating risk factors, so this is intervention. But just observing and following the, for example, the cases, this is not intervention, because we are doing nothing about the risk factors. We are just observe. We do not change it.
Sorry, I have a question. For example, we give a medication for patients. We follow the patient the long term. Or this medication has been given to patient previously, and we know we evaluate the records of the patient that was happened to them. So we did some intervention. We gave the patients the medication. Is it prospective or retrospective? Can be called?
Do you have? Can you hear me? I think there is some problem.
Yes, I can hear you clearly. Can you hear me, Professor Khami?
Dr. Shamshiri asked Dr. Shamshiri to answer. Continue. Ask Dr. Shamshiri to continue.
Okay, guys, can you hear us? Can you hear the voice of me?
Yes. Have your voice in the room. I think we lost Dr. Khami.
Okay, so I will ask the question that I have from Professor Khami later at the end of the session, as I told in the introduction. So I will ask Professor Shamshiri to kindly come to stage, and we are waiting impatiently for the presentation of Professor Shamshiri. The stage is yours, please.
Hello, everybody. Thank you very much.
Your voice is not high enough. Would you please make your microphone louder?
Better now?
No, unfortunately not.
Can you?
Yes.
Can you see my screen?
Yes, we can see that, and your voice is much better now.
I'm back. Can you hear me?
Yes, now we can hear you, Professor Khami.
Okay.
But I will ask my question later at the end of the session. Anytime you will let me, I will ask my question.
Okay, thank you.
Hello. Yeah, can you hear me?
Yes, clearly.
Oh, excuse me, I can't hear you. Okay. Hi.
Would you please talk a little bit?
Okay. Is it better now?
Yes, but you had to keep the microphone in front of your mouth in order to hear your voice.
Okay.
During the talking, and as much as possible, please talk louder in order we can hear you.
Okay, of course. And
Thank you.
can you see my screen?
Yes, we can.
Good. So with your permission, I will continue.
Please, but please speak louder because it is a little bit difficult to hear you properly.
Okay. Okay. 1, 2, 3.
Yes, I can hear it 1, 2, 3, but it's not the voice is not
It's
loud
not
enough.
high enough. Okay.
So we might sleep with this level of tone of sound.
Okay.
Maybe, Dr. Shamsi, maybe you should put your, I mean, your volume on a higher level in your control panel.
My speaker is at the highest level.
Uh-huh.
The microphone, I think, should be the highest. I think. Okay. I try to speak louder. Okay.
It has been written that it was better without hands-free. I don't know. It depends on the laptop that Professor Shamshiri has.
Okay. What about now?
Great. It's absolutely great. Wonderful.
Okay.
You
Okay.
cannot sleep anymore.
Now,
okay, it started.
Okay, I have 3 presentations today. One about principles of critical appraisal, and the other one is about standardized reporting guidelines. And after break, we will review some critical appraisal of observational studies. I mean, as Dr. Hami said, cross-sectional studies, case control studies, and cohort studies. Now, in first session, we review critical appraisal definition, general consideration, and general questions for appraising evidences related to observational studies mainly. And first of all, I want to review the definition of evidence-based practice again, which is the integration of best research evidence with clinical expertise and patient values. And I want focus in this definition on clinical expertise. It should not be interpreted as expert opinion. The clinical expertise, as noted in the picture below the slide, is your clinical judgment, not expert opinion. So, as you know, for evidence-based practice or evidence-based dentistry, we have at least 5 steps: forming answerable questions, searching the evidences, and now we want to critically appraise our findings in the databases. So what's the meaning of critical appraisal? The critical appraisal referred to the application of predefined rules of evidence to a study to assess its methodological quality and then the clinical usefulness of its results. So we should at first be certain that what we found in the databases are valid according to the methodologic points of view, and then we should focus on the results and find that is their finding are clinically useful for our patient or not. This is another definition by CEBMA from Netherlands, which say critical appraisal is the process of carefully and systematically assessing the outcome of scientific research or evidences to judge its truthworthiness, value, and relevance in a particular context. And critical appraisal looks at the way a study is conducted and examines factors such as internal validity, which is points to the how we, for example, enrolled patients in our studies, and how we are define a certain criteria to measure study variables, those independent variables and dependent variables, and other factors related to generalizability, which shows us that the study results, is it pertinent to our patient or not? And again, the relevance of the results to our clinical setting. So as some textbooks and sources noted, this step, I mean the third step in evidence-based dentistry, is the most technical step in the process of evidence-based practice. If you find some evidences from appraised sources, I mean guidelines or systematic reviews from Concurrent, you could be confident that these evidences are appraised and good to use in your clinical settings. But other resources, even if they claim that they had critically appraised their evidences in their websites or in their journals, but you should have a minimum expertise to critically appraise those evidences, and yourself, you should be confident about the results of those evidence. Okay, here's some initial appraisal questions you could ask for every evidence. I mean, observational studies, guidelines, systematic reviews, randomized controlled trials, and so on. The first one is the evidence from a known reputable source? As I mentioned, if you get your answer from a national guideline, so it's both known and reputable source for your practice. But if you find your answer in PubMed or Medline, the answer is not. The second question, has the evidence been evaluated in any way? If so, how and by whom? So again, it's emphasized that who critically appraised the source that you find in the internet, for example. Is it a peer-reviewed journal? So it's not top level of critically appraised. But if you find your answer in Cochrane systematic review database, you can rely on the results of that systematic review. And how up-to-date is the evidence? It's very important. It's very important. One thing that you should consider is that those who provide the best evidences for practitioners have some expiry date for their evidences. For example, for a systematic review, maybe 2 years is maximum usage, and the authors should renew their searches and add the new evidences to their systematic reviews, for example. And also guidelines and national guidelines should be updated frequently. So it's the difference between the evidences and primary studies. The second questions look at the study itself and ask the general appraisal questions. There are 4 questions here provided to you. How was the outcome measured? The outcome means your clinical endpoints. Is that a reliable way to measure? That means, is the authors or researchers select a good study design for their research question? Can they control confounders or biases in their studies? And other points that it's specific for each study and designs, which we speak about them in each study design separately by its appraisal tool. The third question, how large was the effect size? And here I want to ask you to focus on clinical importance of the findings. The effect size actually is a biostatistical or a statistical terminology. But in evidence-based dentistry, when we speak about the effect size, think about the clinical importance. For example, if you have routinely a method for your patients and you have a successful results at, for example, 80% of cases, when a company come to you and said, our intervention make your successfulness from 80 to 85%, this 5% increase of success, is it clinically important for you and your patients? You should think about these differences between the study groups, routine groups and new intervention groups. Maybe 5% in some cases be important. For example, when you speak about the survival rate of the cancer patients, but for other minor diseases, maybe 5% actually is ignorable. And the last question in this slide is that what implications does the study have for your practice? Is it relevant to you or not? Maybe some answers to the question be classified for specialties, and in general practicing it's not sufficient or appropriate. So those evidences for hospital should be practiced in hospital, not in the office. And those evidences for the office may be not appropriate for the hospital or clinics. So a question, which one is related to the effect size of a study result? Send 1 if you think it's clinical importance, and send 2 if you think it's statistical significance. Okay, thank you. Very good. So as I mentioned, it's related to clinical importance. Thank you again for all of you. Okay. Now, I want to show you a brief on how to read a paper or the evidence. If you look at the appraised article and you found it methodologically sound, then look at the results for clinical importance. If it is important, so go ahead. But if you find it's not clinically important, take it away. If it is important clinically, now you should look at the statistical findings, I mean p-values. If the p-value is meaningful and significant, so the clinically important findings could be reliable and you can apply the findings. But if the clinically important finding is not supported by the statistical method and get non-significant p-value, it shows that the power of a study is low and it's not be reliable. I think it's a very important slide in my presentation. Here is my references for this presentation, and I have 30 minutes for the next presentation. Is there any question now?
Thank you. Thank you, Professor Shamshiri. It was great. May I have a question?
Of course.
About the effect size. You gave an example about the effect of a medication. For example, if a medication is produced by a company and it has a significant effect of, for example, improving the health of patient about 8%, but if another medication produces by a company and causing improving of the medical health of the patient 85%, this 5% is defined as the effect size?
Yeah, we said that is as an effect size, and you should decide that both for this difference of effectiveness and the cost you pay for this 5% gain. So the cost also is important, and you should speak with your patient and decide that, for example, in your practice, you may find that the new treatment is better than the routine, but the patient may not be accept to pay for that.
Is there any clear definition for the effect size?
Yeah, actually, by a statistical method, it has a formulations, and there are some categorization to say that the effect size is high or moderate or low.
No,
but
definition of that term.
The effect size.
Yeah, just the definition of that term. Would you please let us know?
Yeah. The effect size means that the effect that you gain by new treatment, is it high or low? In evidence-based dentistry, it's equal to clinically important terminology, yeah?
Okay, and it depends also, so the factor of cost also has an important effect on the effect size, the cost.
Yeah. Yes, you are right.
Thank you.
You're welcome.
So thank you, audience, for your participation. Probably we have a short break, isn't it, Professor Khami?
Yes, according to the program, now Dr. Shamshiri should continue.
Yes.
his second part of presentation, and after that we will have a break.
Okay, there is a question of one of our participants. The question is from Professor Shamshiri. You can read it in the chat box. And the question is that, is it correct that we couldn't rely on companies' search? It is the question, Professor Shamshiri.
Of course, no, we can't rely on company search, but beware that their studies are supported by them, and maybe is I want to say it's a conflict of interest. They pay for the researchers, and maybe the results deviated to their intervention. And the second one is that the companies focus on statistical significance of the differences, not clinically important. So most of the studies which supported by the companies have a large sample sizes and huge participants enrolled in those studies, and with huge number of participants, statistical significance gained for a small effect size, small differences between treatments. So be careful that your justification and judgment should be based on clinical importance and then a statistical significance. So if you good reader of the papers, even the papers supported by the companies could be reliable and informative.
So by your explanation, a question appeared on my mind about the corona. Last night I found that the two type of vaccine, one from USA and one from Oxford University, has been released, and it was injected to the patients. So can we trust on the result of those companies because they have a study on the large population before that? Because we have no effect size now. Do we have?
It's a great example. As you know, the vaccines are highly sensitive interventions on the population, and Ministry of Health of each country, and also WHO, World Health Organization, there are the very restrict regulations to accept the results of trials on vaccines. So I think when the vaccines are certified by international agencies such as WHO and is validated by the food and drug organizations in each country, everybody could rely on them. But in some cases, I want to present another example in COVID context. For example, remdesivir, it's highly supported by the Gilead company, and there are very controversial results from different studies. And as you know, in the US, the CDC prescribed the remdesivir for critically ill patients in ICU, for example, and not intubated. And for example, in our country, in Iran, it's not included in the treatment protocols. But it's different from vaccines, which is generally introduced to the healthy people and population in all over the world, and it's highly sensitive. So we can rely on vaccine certifications.
So we should trust on them. Thank you, Dr. Shamshiri. There is a question from Dr. Mustafavi that has been written. Do you want me to read it for you?
When the result of a study is statistically significant but not clinically significant, statistically significant but not clinically important. So can we say that the researcher did not consider the clinical difference, which is important from the first of the study, and maybe they do not know the clinical difference, which makes sense? Yes, as I mentioned, for for commercial interventions, it's happened frequently when the foundation provided by those companies, they know that they can't get a significant difference between their intervention and routine intervention, and they raise the sample size to get significant p-values. And the audience should be aware about the clinical importance. Maybe the researchers also know that this clinical difference is maybe not important. However, in some cases, maybe the patient ask the doctors to get the best treatment, even if there is a significant difference with routine care. It depends on the patient, and it could be informative in these cases. And these studies have a high statistical power, so we can rely on them more than other small studies. But we should beware about the clinical importance. We should discuss these differences and the cost with the patient.
It is one of the three circle you included in the first slide you shows, the patient's idea, the patient's perceptions of the treatment. That overlap together at the end, evidence-based dentistry or evidence-based result was in the middle of the overlap of the three circle. Thank you. It is a very clear answer to our question. Appreciate it. So we are waiting for the next presentation of you, Professor Shamshiri, please.
Okay. So here my next presentation is standardized reporting guidelines. And here the guideline is not the clinical practice guidelines. I want to show some instructions or checklists for reporting the studies. It may be more beneficial for the researchers, not practitioners. But if you know how the researchers report their study outcomes and, for example, methodology and results, you can better find the important part to appraise them. So here I provide some checklists for different studies. The most famous is Consort checklist for randomized controlled trial, STROBE for observational study, PRISMA for systematic review, ESPRIT for making a randomized controlled trial protocol, STARD for diagnostic and prognostic studies, CARE for case reports and case series, the AGRI checklist for clinical practice guidelines, SRQR for qualitative research, ARRIVE or ARRIVE for animal or preclinical studies, SQUARE for quality improvement studies, and CHEERS for economic evaluations. For example, cost effectiveness analysis or cost minimization studies, and so on. Here I want only just show you the STROBE statement because my next presentation is related to analytical and observational studies. Here they provide a combined checklist for cohort case control and cross-sectional studies. As you see here, they start from the title and they have two items for title and abstract. The first one, 1A, indicate the studies designed with a commonly used term in the title or the abstract. Here they emphasize that the readers should get the study design from title or abstract. And the next one, 1B, is provide in the abstract an informative and balanced summary of what was done and what was found. So the reader could find rapidly that this evidence could answer his or her question or not, and then can decide to read the full text or not. The first part of the full text is introduction, which starts with background and rationale, and followed at the end by the objectives, which should be clearly stated. Because in evidence-based dentistry, we have clear questions. The majority of this checklist is paid for methodology. It consists of 2 slides. A study design, present key elements of a study design early in the paper. As you know, for each study, we have some sub-studies. For example, we have, I will introduce you some of them. For example, for cohort study, we have historical cohort study, we have concurrent cohort studies or mixed cohort studies, we have trend studies, we have panel studies. All of them are cohort studies, and we should, researchers should clearly state the study design in the method. The setting is important. As I told you, the setting, in the office, in the home, in the clinic, in the hospital, it should be stated. And maybe some studies perform a multi-center studies, and it should be stated clearly, because multi-center studies, in case of generalizability, is better than those studies which perform in single centers. Vice versa, those studies run in a single center have an internal validity higher than those studies run in multiple centers. So we should think about that, which one is better for our patient. Those studies with high internal validity or those studies with high external validity. The external validity is equal to generalizability. And the next item is related to participants. For cohort studies, it should be given the eligibility criteria and the sources and methods of selection of participants. And the follow-up method should be described. I will tell you that the follow-up is very important for cohort studies. For case control studies, again, eligibility criteria should be provided, and also the sources and methods of case ascertainment and control selection. The control selection for case control study is very important. And given the rationale for the choice of cases and controls. And for cross-sectional studies, again, eligibility criteria should be provided, and the sources and methods of selection of participants. As Dr. Khami mentioned, for cross-sectional studies, we have the researchers should clearly state who, when, and where in their methodology. because when you repeat the cross-sectional study in different locations and different population in different times, you get different results. Okay. And for advanced designs for cohort studies and case control studies, maybe the researcher use matching, and the matching strategy should be defined clearly and their consequences, because when the researcher choose a match design, they should perform match statistical analyses. So it's the match studies are more complicated and should be critically appraised carefully. The next item is variables. We categorize variables as outcomes or exposures or predictors or potential confounders and effect modifiers. All of them have their methodological definitions. Maybe you know, otherwise you can find them in the epidemiologic books. For outcomes, which is mainly the diseases, should be clearly define the criteria for diagnosis of the outcome, and they should provide them objectively in the study. The eighth item is data sources and measurements. For each variable of interest, the researcher should give sources of data and details of methods of assessment or measurement. Always we say that the methodology should be written in a way that everybody from this methodology could be able to repeat the study exactly as the researcher performed. So the comparability of assessment methods in each group should be certified. It's an important item in the studies that have more than one group, 2 groups or higher. The act of the researcher in each group should be consistent, and it's very important. The continue for the method is about the bias. Bias means systematic errors. The systematic errors. Those errors that make the results overestimated or underestimated. Opposite of systematic errors are random errors, which is different from systematic errors. This systematic errors should be explained in the study, and the researcher or authors should be written how they correct or eliminate the systematic errors from the study. We have 2 main categories of systematic errors, one for selection bias and one for measurement bias. For selection bias, we should be certified that the participants in the study are representative from the population. I mean, for example, if the population smokes in 20%, in our sample, it should be 20%. Or if in the population, they become sick in 5%, our study population in a cohort should be end with 5% diseases. Then we can be confident that our sample is representative and there is no selection bias. In other category, I mean measurement bias or information bias, we should use a calibrated methods. We should use similar methods in both study groups with noun sensitivity and specificity. If it is important, for example, in those studies with different observers, for example, in surveys, that it was one of the questions of the participants, a cross-sectional survey. Most of them are held in a total population, in a city, for example, or it's a national survey, and it's obviously not possible to perform by a few observers or interviewers. So we should have some calibrations or some training courses for the observers or interviewers to assess and measure and ask the questions in a similar manner all over the study. And for long-term studies, these courses should be repeated frequently, for example, each month if needed. The 10th item is about a study size or sample size. The study size, it's targeted the random error. The study size, if it is adequate, is enough, we could rely on random error. But for small size studies, the random error is high and the statistical power is low. About the quantitative variables, as 11th item, explain how quantitative variables were handled in the analysis. If applicable, describe which groupings were chosen and why. You may know that in statistics, we mainly have two types of variable: quantitative variable and qualitative variable. Quantitative variables are those variables for example, we count them. For example, a number of decayed teeth, or DMFT, or age, or weight. In other hand, we have qualitative or categorical variables, such as gender, male or female, such as, for example, age groups. For example, preschool age, or then after, or childhood, adolescent, young and old, for example. These types of data. In studies, we preferred to gather data in quantitative manner. So if we have, for example, two options, for example, measuring pain in a numeric scale from 0 to 10, or we can ask the pain as yes or no, it's better to measure the pain in a numeric way. But we can deal with this one in the statistical session. We can change the numbers to the categories, and it should be described here. In the last session of the method is a statistical method, and it may be sophisticated for some of our participants, but here, as a general rule, the study question is defined in the introduction. The method of measurement of the variables are provided in the method section. Now, in the statistical methods, the researcher should mention the study hypothesis. The study hypothesis. And for each study hypothesis, they should provide an appropriate statistical method with its details. And the details are related to the experts who knows the biostatistics, but in general, the audience who wants themselves to critically appraise the evidence, they should know which variables should be handled with which statistical method. And for experts who deal with a few variables in their clinical practice, they can get the appropriate statistical methods when they read frequently the articles in their expertise and in their fields. So the experts could differentiate between correct and incorrect statistical methods without expertise in biostatistics, I mean. And the next one is about the results. Mainly, the first section of the result should be focused on the description of the participants in the study. And then it should be go through a statistical analysis and should be end with some detailed or a subgroup analysis. Or maybe we can divide the statistical analysis to a simple analysis or 2x2 variables analysis. And at the end, it should be provided by multiple analysis. I mean, for example, with multiple regression analysis and so on. I want to go through this section. And the next one is the discussion, which is very important for not methodologists, but for you, for practitioners, because the scientist or the researcher, after providing you their study results in discussion, they try to emphasize on the associations between the variables, and they want to say that these associations are causation. Because if the association change to causation, you can change your practice, and you can be hopeful to get the results from this intervention. Because the association itself is not important and could not affect your practice. The associations should be close to causation, and it's very important. So in the discussion, the authors try to make a link between association to causation. For example, by providing similar studies, and they point the consistency of the results. They want, for example, to show the dose effect relationship between the, for example, dosage of the drug and the cure rate in the patients. Maybe they provide some biologic mechanism to show that the effect of the intervention through the noun mechanism lead to the cure, and so on. So the discussion is very important to you. And here they should provide the limitation and their strengths. And if they mention clearly, you may better rely on the results here. And the last one is the foundation or conflict of interest, which is asked For example, here is the budget of the studies funded by a company or no, or something else. It's the meaning of the providing foundation is not that you put aside those studies from companies, but you should think that in some cases, when you read the results and the discussion, you should be very careful that maybe this support affect the final decision of the article. It should be your concern, and it's not the meaning that is a bad point in the article. And now my question here is, do you want a break? If you have any question, please write it down. Oh, great, one.
Professor Kamil Shamshiri, do you want to have a short break for the audience and then continue, Professor Shamshiri?
According to the schedule, we should have, I think it's a 15 minutes break.
Professor Khami or Professor Shamshiri?
It seems that Dr. Motawassilian now is disconnected.
Your picture has.
Huh?
Yes, again.
It seems that. Okay, now I think it's okay now.
Yeah, it's fine. Professor Khami, do you let the participants have a short break before the continue of the?
Okay, yes, sure. So we will start after 15 minutes from now.
Okay, 15 minutes later, we will see the participant and the audience again. Have a good break in this for 15 minutes. See you later. Thank you, Professor Shamshiri. We'll hear you again after 15 minutes. Appreciate it.
Okay. Thank you very much. can I start my last presentation? Dr. Mutawassilian or Dr. Khami?
Yes, I think maybe after 2 minutes.
Good.
Dr. Shamshiri, just would you please? There is a music in background of your voice.
Yeah.
If maybe it compare with your voice when you are presenting your slides. I would be grateful if you
Okay.
mute it. Thank you.
It's fine.
Professor Khami, can we start now?
Yes, sure.
Okay. Professor Shamshiri, please, we hear you.
Thank you. Hi again. My last presentation is about critical appraisal of cross-sectional and other observational studies, I mean analytical studies. Here I again introduce observational analytical study designs and introduce some critical appraisal tools and review one of them and show you the items important for critical appraisal of cross-sectional studies, cohort studies, and case control studies. in category of observational studies, there are three main analytic study designs named cross-sectional, case control, and cohort studies. In analytical studies, we try to investigate the association between at least two variables, here X and Y. We name X as exposure variable, independent variable. In some cases, maybe a risk factor, predictive factors as prognostic factors, or also maybe an intervention in clinical trials, for example. And the Y, which stands for outcome variable, dependent variable, in some cases disease, and endpoints and events. There are different nomenclature of these two variables. Here, the X affect Y, and Y is affected by X. And in analytic study, we investigate their relationship under a study hypothesis. In cross-sectional studies, we have a defined population and we get our study samples by a defined eligibility criteria. And in one time, as a snapshot, we ask about both exposure and outcome in one time. For example, today, do you have any exposure to smoke? And today, do you have any disease? So this is the type of question in a cross-sectional study. Today, do you have any exposure to a risk factor? And today, do you have involved or suffer from a specific disease or not? And we categorize the population or participants to 4 categories: exposed with disease, exposed without disease, unexposed with disease, and unexposed without disease. And then perform a statistical analysis to investigate the relationship between exposure and outcome. In case control studies, we start from the outcome variable. I mean the end of the association, end of the relationship between exposure and outcome. So the direction of the study is from the outcome to the exposure. Here we have 2 groups, one group with outcome and one group without outcome. And as I said before, the outcome mainly is a disease. So a diseased group and a healthy or a group without the disease in the study. This is 2 groups, and we ask them the exposure to the risk factor in their history. So the question is, do you a smoker, for example, in 2 years before your disease diagnosis or not? Okay. So again, the direction of a study is from the outcome to the exposure. The next study, now just look at the left of the slide. For the cohort studies, we have a defined population which is non-randomly or naturally divided to a group of exposed and non-exposed population. and the investigator follow up these two groups and measure or investigate the outcome related to the exposure in future. The direction of the study in cohort studies is from the exposure to the outcome. And because the investigator goes through the events on time with the participants, it's more reliable than cross-sectional studies and case control studies. So always consider the direction of exposure to the outcome, which is also you can see in the randomized control trial from exposure to the outcome is better than the cross-sectional studies and case control studies. Here I provide you three types of cohort studies. One of them is historical cohort studies, sometimes named retrospective. It means that the researcher gets the exposure history and outcomes from the patient's records. So there are some databases for exposures and outcomes in, for example, a registry or in a large population cohort study, and the investigator, without seeing the participants, only get the data from the database and analyze the relationship between exposure and outcome. Here, the researcher have no control on the exposure measurement and outcome measurement. So the definition of exposure and outcome is held by the registry or another study who collect the data. So it's the evidence provided with historical cohort studies is the lowest one. The next one is concurrent cohort studies, or sometimes they said prospective cohort studies, which after starting the study, the participants gradually evaluated and eligible participants enrolled in the study, and the measurement of exposure held by the researcher, and then followed for a specific time and measured their outcomes by the researcher. So all data are valid by the definitions provided by the researcher. So it's the best result of the cohort studies. But it's very expensive and needs time to perform and finish the study. So there are some designs to convince and make them cost-effective for the researcher. We name them mixed cohort studies. In some cases, you have patients in the databases, and you know that some of them get, for example, treatment A, and some get treatment B. And after, meanwhile, you contact with patients and ask them to come to the clinic for example, some examinations to investigate the failure of treatment or some new diseases. So the exposure is recorded previously with others, and the researcher investigates the outcome himself or herself. So the data or evidences provided by mixed cohort studies is something between historical cohort studies and concurrent cohort studies. Here a list of some of critical appraisal checklists for observational studies. Here you can see Robbins checklist, different checklists, i.e. Newcastle Ottawa scale checklist, IHE, JBI, and other checklists that you can use for critical appraisal. The number of items each checklist have is different. For example, I choose here CEBMA have checklists with 12 items, and here JBI for each study have different items, and I select JBI for a presentation to you. Here is a checklist with 8 items for cross-sectional studies. For each item, we have 4 options: yes, no, unclear, and not applicable. So you can quantify the scale of validation for each study. For example, you can provide 1 if it is yes, or 0 if it is no. And for unclear, you should decide it. Most of the cases, unclear is equal to no. And not applicable means that this study, this item for this study is not applicable. So you can omit this item for that study. The first item for cross-sectional studies is where the criteria for inclusion in the sample clearly defined. It means eligibility criteria. So if there are numerous or frequent items for inclusion and exclusion of the participants, the participants became very similar to each other. We say that the study population is homogeneous. Homogeneous sample size provide a great internal validity for the study, but decrease the generalizability. So if your patient which you want decide for a specific treatment for him or her, if the characteristics of the patient included in the criteria of eligibility of this study, the results of this study may be relevant to your patient. Otherwise, if your patient's characteristics is not included in the study, so the results of this study may be not appropriate for your patient. The second question, were the study subjects and the setting described in details? It's again about the subject and settings. As I mentioned before, for example, in office, patients who refer to clinic or hospital or otherwise. And the third one was the exposure measured in a valid and reliable way. So it's something for calibration, considering sensitivity and specificity of the measurement. Is it an objective of the next one? Were objective standard criteria used for measurement of the condition? Is it objective or subjective? Is it acceptable for the scientist or not? It should be investigated thoroughly in the paper. The fifth is, were confounding factors identified? As you may know, the confounders are is a challenging item in the epidemiology. Some of epidemiologists considered confounders as errors, and some of them consider confounders as a separate entity. So, and in some cases, there are overlap between confounders and biases, mainly selection bias. So in case of confounding, the author or investigators should consider all variables that affect the relationship between the risk factor and disease. The causal network should be complete. For example, if in a study they only provide or assess the relationship between, for example, brushing and dental decay or DMFT, and ignore other factors that could affect DMFT, the study is not complete. They should also consider, for example, flossing, routine dental visits, socioeconomic status, and other factors, varnish fluoride therapy, to make the relationship between brushing and DMFT clearly and specifically. If the confounders didn't consider in the study the relationship between the exposure and outcome, almost always confounded by those variables that not considered in the study. So confounding is very important. And after considering the confounders, the sixth question is, were strategies to deal with confounding factors stated? Because we have some strategies to eliminate the effect of confounding from the relationship in consideration. For example, some statistical methods we can use to eliminate confounder, or some methods we use in the methodology, which is more applicable for case control studies and cohorts, for example, matching design, or in clinical trials such as randomization. Next question, were the outcomes measured in a valid and reliable way? Again, as exposure measurement is important, always outcome also is important. And the last question is, was appropriate statistical analysis used? And after answering to these questions, you can decide to include the study as evidence for your practice or not. A similar checklist provided by JBI for case control studies. It has 10 items. First two questions are related to selection bias. The first one, were the groups comparable other than the presence of disease in cases or the absence of disease in controls? So for example, in some cases, early stages of disease could not be diagnosed, and we could put the patient in a control group by mistake. So the definitions are very important. Where cases and controls matched appropriately, here matching is defined by JBI that if you get cases from hospital, you should get controls from hospital. And if you get patients from population, you should get the controls again from the population. So it points to the base of the population. Hospital case, control, hospital controls. Office case, office controls. Population cases, population controls. Otherwise, the study should be interfered with the selection bias. There are 4 questions, 3, 4, 5, and 8. All of them points information bias or measurement bias. The third question asks about where the same criteria used for identification of cases and controls. The next one, was exposure measured in a standard and valid and reliable way? The fifth question, was exposure measured in the same way for cases and controls? It's very important that we use, or the researcher used a consistent method for both groups. And eighth question is, were outcomes assessed in a standard, valid, and reliable way for cases and controls? The sixth and seventh question are pointed to the confounding factors. Were confounding factors identified, which I mentioned before, as I mentioned before, it's related to causal network, and is related to the literature reviews and the researcher expertise in that field to consider all effective variables on outcome as a potential confounders, and where strategies to deal with confounding factors is stated. And last questions, which are very important. Ninth question is, was the exposure period of interest long enough to be meaningful? For example, when we ask about the exposure from the patients and controls in the past, if we go long to past, we interfere with recall bias. The patients and controls could not remember very precisely the exposures. However, recent exposures may not have related to the disease, because we should consider a minimum a period of time between exposure and outcome, and it should be considerably greater than induction period, and it should be considered. And last, again, is about the statistical analysis. So a question, which one is the most important item in case control studies? Appropriate control group or duration of follow-up? Which one is the most important? Of course, all of them important. So which one is the most one? Good, great. Exactly. The most important is selection of control group. Yeah. The weak point of the case controls are the controls. If the researcher take mistake to get appropriate control, the association between exposure and control maybe became underestimated or overestimated. Consider that, for example, a researcher wants to show the relationship between smoking and oral SCC. Smoking and oral SCC. So in a cancer hospital, we have some oral cancer patients. We ask them about the history of smoking. And when we want to select a control group from the same hospital, if we select, for example, patients with lung cancer, which we know that the lung cancers are also related to the smoking, so in these two groups, smoking is high. So the relationship between smoking and oral SCC became underestimated. We should select a group as a control that the smoking frequency is similar to the population. Then the relationship between smoking and oral SCC became fair and real. Almost the last slide is about the critical appraisal items for cohort studies. The item 1, the first item, and the 6 are related to selection bias, where the two groups similar and recruited from the same population. The 6th question, were the groups and participants free of the outcome at the start of the study? Because we said in cohort study, the direction of the study is from exposure to the outcome. So all of the participants should be disease-free in the start of the study. Items 2, 3, 7, and 8, again, is related to the information bias and measurement of the variables. 4 and 5 is related to the confounders and the methods for eliminating the effect of confounders. 9 and 10 is new, as important for cohort studies. Was follow-up complete? And if not, were the reasons to loss to follow-up described and explored? Were strategies to address incomplete follow-up utilized? So as you see, follow-up is very important and critical for cohort studies. If follow-up of the study is incomplete, for example, if the researcher started with, for example, 500 participants and end with 400 participants, and through the follow-up 100 lost to follow-up, so the composition or the characteristics of the 400 participants at the end of a study may not similar to the 500 participants at the beginning of the study. So the loss to follow-up itself is a type of selection bias. So be careful about the loss to follow-up, and it's completely different from the sample size. So if the researcher, for example, starts with greater number of sample size to finish the study with 500 participants, it's again, these 500 participants are deviated from the characteristics of those participants at the beginning of the study. So here, divide these two entities. the sample size only related to the random error, and loss to follow up is related to the selection bias. So it's not important with which number you start. If you have loss to follow up in the study, so the final results, it's potentially affected by the selection bias. And the last item is again about the appropriateness of statistical analysis. Okay, the last question. Which one is the most important item in cohort studies? Loss to follow up or duration of follow up? Great. Again, both of them are important, and the loss to follow up is more important. Yeah. Thank you very much. It's my references for this presentation. And I'm waiting your questions, if any.
Thank you, Professor Shamshiri. It was very informative and useful for us, and I'm sure it is about for participants as well. Some question during your presentation was written in the chat box. Do you want me to read by one to answer them?
Yes, of course.
I start from the last question from Dr. Paktaman. Dr. Paktaman asked that whether bias is addressed or bias refounded.
Oh, good question. The researchers should address the bias. So it's very important. There are differences between those researchers who address the bias and those who do not care about the bias. Again, I point to the discussion session of the section of the articles, which should be provided by the authors about the limitations and strengths. The limitations, it's very important, and it should be mentioned by the author, and it's we can rely to those studies who honestly said their limitations and strengths. And we should seek about the biases in the study ourselves. So both of them are important, yes.
So during the critical appraisal of, for example, of a literature, we should search about whether the bias has been addressed or not.
Yeah, of course.
Okay. And another question was that the difference between historical cohort and case control.
Okay. And case control and historical cohort, as I mentioned, the direction of the studies are different. For case control is from outcome to exposures. So the investigator gets one disease group and one healthy group and investigate the exposure in past. And for historical cohort, the direction is from exposure to outcomes. So as it is a historical, from their patients' records, they provide two groups, high-risk group and low-risk group, exposed group or unexposed group. And in the records, they seek about the outcomes. So two groups are not diseased and healthy. In historical cohorts, the study groups are exposed and unexposed. It's the difference between these two designs.
So one of them is about the exposure, the other one is about the outcome.
Yeah, yeah.
Okay. And the other question was that is case control study is a cross-sectional study?
Actually not.
No.
But in some cases, the exposure and we have different exposures, and how the questions presented and asked from the participants is important. If they ask the exposure in one time, so it's cross-sectional. If they ask the exposure from the past history, it's became case control.
Would you please repeat again? I didn't understand it.
Oh, okay. For example, if you ask the patients, are you smoke cigarette today? The answer used for cross-sectional studies. But if you ask the smoking in the previous year, and you want to relate the previous exposure to the outcome from this year, it's became a case control study.
Okay, thank you. And the first question was one of the participants asked, and I think it was answered, but if it is not clear yet for you, the audience that asked this question, an example of critical appraisal. Professor Shamshiri during these presentations gave us different samples of critical appraisal. I think it is clear now for you. If the audience that had these questions, any other question, please write in the chat box or ask this question. It is my question that I ask now. Is it possible to ask the question now?
Of course.
Yeah. For the cohort non-randomized study, that there is a group of exposed, another group is unexposed. Is it ethical?
Yeah, difficult question. Why it's not ethical?
Because in intentionally we choose two groups that one of them, for example, has been exposed, exposed to a medication, and the other group intentionally doesn't give the medication.
Good.
Because it will have an effect on the health of the patient.
You are right. But non-random, it's not that we intentionally give the intervention to one patient and intentionally omit or withdraw the intervention from the others. Consider, I think you interested with COVID.
No, it is a question in my mind that whether it is ethical or not.
But I have a good example for COVID treatment. One of the strategies for treatment of COVID is plasma therapy, convalescent plasma therapy. Plasma from the cured patients to the critical ill patients. As you know, in first days, the donors of plasma very limited, and few patients come to donor their plasma. So when we have plasma for patients, we give the patients the plasma. In other days, when we have no plasma for therapy, the patients treated with other treatments. So in this case, there is no randomization. And it's not ethical.
Yes, so we do not randomly, intentionally select the patient, and because of that reason, it is ethical.
Yeah, of course.
Okay. There was another question, I think it was from Dr. Mustafavi about in vitro study. Let me, oh, I'm sorry. I cannot read it. Dr. Azam Mustafavi asked about the in vitro studies that Dr. Lady has asked that since many in vitro studies are performed in the field of dentistry, which scale or checklist do you propose for appraising them for the in vitro study? Which checklist do you use for appraising them?
I think I have provided. A checklist for in vitro or experimental studies, I think so.
Okay, by this way, there is a checklist for appraising in vitro studies as well.
Yes, 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 of course.
Okay.
Also, we have checklists to appraise expert opinions. Yeah. So for experimental, of course, we have. Yes.
Okay. And so, do you have? Can you introduce the name of some of them?
I will write it in the chat box for you.
Okay. And again, Dr. One of the audiences asked, sometimes in cross-sectional study, we ask about the duration of time in the past, like past year. So it is cross-sectional study or case control study?
Okay.
It is the last question.
It's an advanced question because in some cases we have a mixture of cross-sectional and, for example, case control studies. Some of the variables or risk factors we ask, for example, such as gender, it's not for present, it's for past. Okay, and some variables are just for present, not past. So there is a mixture of the variables and risk factors, and we should be careful about the interpretation of the results. You are right. So for these cases, it's not important what's the name of the design. You should focus on how the variables measured.
And another question is that, which is ideal scale or checklist, which is ideal scale or checklist for doing critical appraisal for all studies? I think the audience asked, would you recommend any checklist that is much better than the others that we can trust on?
No, of course not. It depends on the field you study for that. In some cases, we ought to make own checklists when we, for example, run a systematic review. We get some questions from this checklist and from that checklist, and maybe we add some questions because the importance of that point in the field.
During your explanation and presentation, you mentioned the point that for each type of a study, there's a definitive type of checklist, so we should refer to them. Is it right?
Yes, of course. Yeah, for example, CAS.
So it depends on the study.
Yeah, of course.
It depends on the study. And another question, design of a study is cross-sectional, but we add history. Do you understand this question to answer this audience?
Again,
Zahra Saeed Muallemi asked this question.
Design of a study is cross-section, but we ask history. I think it's mentioned by another participant. Yeah, don't think about the name of design. Only focus how the variables are measured. Some of them may be measured from the past, and some of them may be measured from present. The validity of measurement is more important than the design itself.
That's right. It depends on the time. It depends on whether we evaluate the outcome. It depends on whether we evaluate the exposure. So all of these factors can clarify that what is the design of the study. These case control studies, historical cohort studies. So according to definition of Professor Shamsuri, we can define them and categorize them and classify them. Is there any question else? So apparently there is no questions. Professor Khami, do you recommend anything? Please let us know, please.
Okay, thank you. Thank you, Dr. Shamshiri, for his I think very nice presentation, and I think very good discussions about these observational studies, case control cohorts, historical cohorts, and so on was done. So if still there is any question, just the participants can write down in the chat box, and we will have time at the end of the presentation. Is there any problem with my voice? Can you hear me? It
Yes,
seems that
your voice.
Okay, so my voice is clear. Okay.
Excuse me,
So,
Professor Fahmy, there is a question from you. What is the historical trial? I think it was clearly explained, but it is a question. I do not know. Do you want to, in brief, explain about this question?
Yes, I talked about some trials that they don't have contemporary controls. They have historical controls. And this means that, for example, you are doing a routine, for example, and you are prescribing some certain drugs to the patients. Then you discontinue that and you start to prescribe some other medications or some other drugs. Then your controls are not treated at the same time as your, for example, intervention group. This can be called historical trial. Okay, and as we see in the hierarchy of evidence, the historical trial or the trials with historical or non-contemporary controls, their level of evidence is somehow lower than a classical randomized control trial.
May I have my question?
Okay.
From you.
Sure.
I didn't understand properly the quasi-experimental studies, the quasi during the classification of your study during the,
Yes, you know that quasi means semi, so not complete experimental. The difference could be in two aspects. One is the randomization, and the other is in having or not having control group. So if you do not have control group, your study is quasi-experimental. If you don't have randomization in your study, I mean random allocation. So the situation is like that. You cannot have random allocation. You cannot call it a true experimental or controlled clinical randomized control trial. So the difference comes from these two aspects: randomization and having control group.
So a question appeared in my mind: when there is no control group, when there is no randomization allocation, is this type of a studies reliable to design?
In its position, we could see its position in the hierarchy of evidence. We will now review it. Because I want to say also another point about the hierarchy of evidence. Certainly, because of these problems, it is not as valid as classical randomized controlled trials.
So
but we know that in reality, it's difficult sometimes, and it's sometimes expensive to do a classic randomized controlled trials. And the ethical issue also important, sometimes because of the ethical issue. And because of this ethical issue, for your control group, you should have the best available treatment. So your control group should receive the best available treatment, and the intervention group receive the new drug or technique or so on.
According to the explanation of Professor Shamshuri, one of the items for critically appraising research study, one of the items was, I think it was having a control group or randomizations. So by this way, this type of a study can be considered for critical appraisal?
Yes, sure. The next presentation, in the next presentation, I will talk about the critical appraisal of randomized of clinical trials, and we will have something about this.
Okay. Thank you. I appreciate it. Thank you.
So you're welcome. Just coming back to the hierarchy of evidence, I just want to say one.
Professor Khami, sorry, there are two other questions. Do you want to present your, or do you want to answer the question? Which one do you like?
Maybe we can see the questions first.
So if you want, can you see them?
Okay. What is the question?
Let me. Okay. And one of the questions was that an example of critical appraising in vitro studies. Dr. Shamshiri has been written. Sorry, it is the answer of the question that given like an example of the standard items for critical appraising of vitro study. That's the name is IVCAT. The other one, another question is CEBM scale is good to follow as a beginner in the research. Of course, it is a question from Professor Shamshiri. Professor Shamshiri, are you available?
Yes.
Would you please answer this question?
Okay. Do you hear me?
Yeah.
Yes.
Good. CEBM is an institute which is focused on evidence-based practice. It's a valid and known center, and I think the scale mentioned here is the level of evidence provided by this organization, which is used in some guidelines. For example, when guideline provide the question and the answer, which we name the answer in the guideline as recommendation, after each recommendation, the level of evidence provided, for example, by A, B, C, E, which is get from CEBM level of evidence. So it's a good source for information about evidence-based practice.
Okay, so CBM scale is it's good for clinical practice for the basic appraisal, not high level.
Yeah, to find the high-level recommendations. Yeah.
Okay, thank you. Okay, Professor, apparently there is no other question. If Professor Khani, you wanted to present some other slides, please.
Yes, okay. Thank you. Just going back to the previous set of slides to tell something about the hierarchy of evidence that we had here. It's now, I think, useful to, again, have a look at this evidence hierarchy. Now we know something about case control studies and cohort studies, and now we can understand that why cohort study is in a higher level of case controlled study regarding the validity of the evidences. And the point that I want to say that each systematic review of any kinds of these studies is placed one level above the study itself. For example, if there is a systematic review of case-controlled studies in a specific subject, so its place is one level above case-controlled studies, but for example, below a cohort study. Or if you have found a systematic review, including cohort studies, so the level of evidence is just one level above the cohort studies and below the randomized controlled trial. This was the point that I wanted to emphasize and mention. Okay, and then we can now go to the next presentation, which is about critical appraisal of randomized controlled trials. With the basics of the appraisal that Dr. Shamshir nicely presented, now it's, I think, much easier to focus on randomized controlled trials. Before that, I just want to present some criteria for critical appraisal, but from the perspective of our questions, our PICO questions. You certainly remember from our second session that we had 4 types of questions. One category of our questions was those about diagnostic tests. So when we have a PICO question regarding a specific diagnostic test, and we want to apprise some of the literature that we have found, we can use these criteria in this checklist. Was the test compared blindly and independently with the gold standard? We know that for the diagnostic test study, we do need a gold standard. And the results of our test, the test in question, should be compared with the results of a gold standard. So the second question is, was the test evaluated in a range of patients representative of a clinical practice setting? It seems crucial that the patients who are receiving the test are similar in regarding the range with that with a sample that can represent a real clinical practice setting, not just selected or patients or those with some specific conditions which may have some effects on the results of the test. The third item is, did everyone who received the new test get the gold standard as well? This seems clear that why this checklist, why this item should be checked when we think about the aim of the study. Then, can the test be replicated in my practice? This is the question that we should ask when we reading any article, when we want to use the results for our clinical practice. Then, do the results of the test apply to my patient? Again, we are concerned about if these results are useful for my clinical routine practice or not. Then, regarding the articles about causation, when we know that, for example, the cohort studies are the type of studies that are usually used for these causation questions. So, and I think these items are the same as, many of them are the same as Professor Shamshiri presented when regarding critical appraisal of cohort studies, that were the comparison groups similar, were the exposures and the outcome measured in the same way in both groups, did the exposure precede the outcome, is there dose response relationship, does the association make sense, or can I apply the results to my practice? So I go to the next slide, and this is assessing article about prognosis. When we have some question about the prognosis of a condition or a treatment, then where the patients will describe the representative and at a similar point in development of their disease, was follow-up sufficiently long and complete? Again, the same as what Professor Shamshir said and presented. Were the outcome criteria explicit and applied objectively, and were extraneous prognostic factors adjusted for? And were the study patients similar to my own, will the results help to select or avoid therapy or provide advice for patients? You can see we have the same question in all of the checklists because the ultimate goal in evidence-based practice is to find some answer to our clinical questions. And then when we come to the papers about therapy, the most useful studies are randomized controlled trials. So you can see the checklist, a brief checklist for assessing and for critically appraising randomized controlled trials. The first and the most important item is that was the allocation of patients to study groups random or not? we talked about randomization and how much it is important. So the first item refers to the random allocation of patients to study groups, and we know that if a RCT fails to accomplish this condition, then the validity would be very low. Were all the patients who entered the trial accounted for and analyzed at the end of the study? This is another important point. Regarding the randomization, I want to add that in addition to reporting that we have randomly allocated the patients to the groups, so the authors should mention that they have randomly allocated patients to the study groups. In addition to that, they should state the method of their randomization and random allocation. They should tell about their method. Okay, and then the second one regarding the dropout. Is there any dropout, or all the patients who entered the trial accounted for and analyzed at the end of the study? Because if we have dropout, then this dropout may be the results of our intervention. So it is not acceptable. Up to 20% dropout can be accepted if it is justified. But more than that, okay, then we will have some problems with the validity of the paper and the study. Just maybe otherwise it should be justified very good. And there are certain justifications for that. The third item is about blinding, where patients, clinicians, and study personnel blinded or not. We should notice that in some of the clinical trials, it is not possible to do blinding, and we cannot expect, for example, the clinician would be blinded, especially when we are, for example, doing a clinical trial regarding 2 technical procedures. So the clinician cannot be blinded because he or she knows that which procedure is being done. So we should have some realistic expectation here. But if it is possible to do blinding, then it can add to the validity of the results. And then were the groups similar at the outset and treated equally throughout the study? So in clinical trials, we try to behave similarly and in the same manner with the 2 groups, but just the intervention would be different. So we should notice when we are reading an RCT paper, we should notice if there is any difference between the 2 groups, how they have been treated, how they have been behaved. This is one of the items. And then were clinically important outcomes assessed? Again, clinically important outcomes. So I think Dr. Shamshiri clearly explained about these clinically important outcomes. Some of the outcomes are outcomes, but they are not clinically important. For example, when you are reading an article about lesions, for example, periapical lesions, maybe the size of the lesion, the size of the periapical lesion can be considered as a clinically relevant and important outcomes. But for example, presence of some specific cells in the histological sections, they are outcomes, but might not, because we don't know if there is any direct relationship between the presence of these cells in the section and clinical outcomes like pain, swallowing, or something like that. So we should think about clinically important outcomes. And the point is that we have defined these outcomes in our PICO questions. And in that stage, we told that you should, in that stage, you should choose and select clinically important outcomes. And again, the maybe repetitive item in all checklists, that can the results of the study be applied to my patients? this is something that we should judge and we should evaluate, and according to that decide whether or not we can use the results of this study in our clinical practice. Dr. Shamshir explained about these standardized reporting guidelines, and one of the famous standardized reporting guidelines is the one who is related to clinical trials. You have certainly heard about that, which is Consort guideline. So there is a website for that, and you can go there. I have it here, so I try to share the web page, and then we can just have a look at it, and then we will go to a checklist, another checklist to evaluate and appraise critical RCTs, randomized controlled trials. So just let me to share that page. Okay, I should stop share here. Again, screen share, and just go to here maybe, and then yes. Okay, this is Consort web page. If you go to the Consort statement, if you want to see the home page of this, I can just can you see now the web page?
Yes, doctor, we can see.
Okay, thank you. So this is the homepage of this Consort, and there are some tabs here. You can go and download the checklist and its extensions, because there is a core checklist, and then there are some extensions. So I want to go to the checklist. And if I open it, it's a Word checklist, but we can also have it here. So it is the 25 item checklist. Okay, this is. Can you see it now? Can you see the checklist in the Word?
Yes,
software?
Dr. Khami. Yes, Professor Khami. It can be observed.
Yes, you can see it. Okay,
Yeah.
No,
this is the Consort. You cannot see it. Okay.
Yes, you just see the browser.
Okay, you see the browser. Okay, I now try to stop sharing this and again come to here, and oh, where is the checklist now? Yes, no, this one. I think this is the checklist. Now you can see it. Yes.
Yes.
Like the checklist.
Yes, the table is observed.
Yes, like the checklist that we had for example, cohort studies, observational studies. Here we have, for example, in the title and the abstract. So the first question is on the identification as a randomized trial in the title. So in the title, it should be stated that this is a randomized trial. And then regarding the abstract, the structured summary of trial design, methods, results, and conclusions should be stated. Then when we come to introduction, and we are talking about background and objective, scientific background and explanation of rationale and specific objectives or hypotheses should be included in the introduction part. I go back to the web page because there we can see also some examples. So if I go to the website, yes, you can see the website now. And if I click on the checklist, then in the right side, you see again that the items of the checklist, and the left side you will have an explanation of the item and also an example of that. Maybe there is some problems with my internet connection, because it takes a times. It seems that it takes times to upload the web page. Maybe I should do it again. Okay, till that, it seems that there is some problems, but I can show you another checklist, which is CASP. This is CASP, and CASP is Critical Appraisal Skill Program. Here also we have some checklists, and one of them is you can click on the checklist. You can see the checklist here. For example, for CASP for randomized controlled trials, CASP for systematic review, CASP systematic review checklist, CASP qualitative studies checklist, cohort study checklist, and also in 2 formats of PDF and print and fill. So I just click on the PDF form. So can you see now the CASP checklist, CASP Critical Appraisal Skills Program?
Yes, yes, Professor Khan.
Yes. Okay, so here is 11 questions that have been designed to help you think about these aspects systematically. And there is an explanation how to use this appraisal tool. So you can study these explanations before going to the checklist itself. But I want to directly go to the checklist, and you can here see how it works. For example, it has 3 sections, as is mentioned here. 3 sections. Is the basic study design valid for a randomized controlled trial? Some items regarding to this question have been included in the section A. In the section B, we have some items that clarify, was the study methodologically sound or not? And in the section C, we will see what are the results. And in section D, it has 4 sections. In section D, will the results help locally or not? So we will go to the section 1. So the first question is that, did the study address a clearly focused research questions? And when you want to decide about this, you should consider, was the study designed to assess the outcomes of an intervention? Is the research question focused in terms of population, intervention, comparator chosen, and outcome measured? You can see PICO here. So it requires a randomized controlled trial also to have a PICO format for its aim, for its question. And you can choose yes, no, and can tell, and write anything you want here. The second question is, was the assignment of participants to the intervention randomized? And we should consider, how was randomization carried out? Was the method appropriate? As I told you, the method should be stated. Was randomization sufficient to eliminate systematic bias? And we should judge, we should evaluate this, we should consider this. Was the allocation sequence concealed from investigators and participants? So these are the questions that we should consider regarding the second item. Again, we can choose yes, no, or can tell. And then the third question is, were all participants who entered the study accounted for at its conclusion? We saw these items also in the previous checklist. They are not new, but just to know, these are the main items. Were losses to follow-up and exclusions after randomization accounted for? We should not have a significant dropout, and if we have some dropout, it should be justified. Were participants analyzed in the study groups to which they were randomized? Because this sometimes happens that some of, for example, patients or subjects in one of your groups, they, because of any reason, they move to the other groups. And here, you can do intention to treat analysis or some other kinds of analysis. When you do intention to treat analysis, you just, irrespective of these subjects, you just continue to analyze the patients in the both groups. So you disregard this movement of some of the subjects to the other groups. So this is intention to treat. So if you exclude those if you exclude those in your those who have moved from your one of your groups to the other, and exclude those in your analysis, you exclude those, then it is per protocol, because this is another kind of analysis. This is just to know why this intention to treat means, because these in these analyses they are biostatistical aspects of randomized controlled trials, and I want just you to be familiar with these terms. And if you exclude those moving to this to your other group and treat them in the new group, then this is on treatment analysis. Because just to know that here intention to treat means that if some people from one of your groups have been moved to the other groups because of any reasons, if you do your analysis irrespective of this movement, then this is intention to treat analysis. Then was the study stopped early? If so, what was the reason? This is the other point that should be considered. Then we will go to the section B. In section B, we have where the participants blind, regarding blinding to interventions they were given, where the investigators blind to the intervention they were giving to the participants, and where the people assessing or analyzing outcomes blind. Because as I told you, we have three kinds of blinding, and if we have all these three, then the study is triple blind. The fifth question is where the study groups similar at the start of the randomized controlled trial, and we should consider where the baseline characteristics of each study group, for example, age, sex, socioeconomic group, clearly set out. Were there any differences between the study groups that could affect the outcomes? The sixth question is apart from the experimental intervention, did each study group receive the same level of care? That is where they treated equally. As I told you, the two groups, for example, should be treated equally. And we should consider, was there a clearly defined study protocol? If any additional interventions were given, for example, tests or treatment, were they similar between the study groups? And were the follow-up intervals the same for each study group? This is end of the section B. And in section C, which is what are the results, then we are thinking about where the effects of interventions reported comprehensively. Was a power calculation undertaken? I think Dr. Shamshiri said something about power and its relation to sample size and so on. What outcomes were measured and were they clearly specified? How were the results expressed for binary outcomes? Were relative or absolute effects reported? Then were the results reported for each outcome in each study group at each follow-up interval? Okay. Was there any missing or incomplete data? Was there differential dropout between the study groups that could affect the results? And were potential sources of bias identified, as it was discussed in the previous presentation? Which statistical tests were used and were p-values reported or not? So this is a seventh question. And now in the question 8, was the precision of the estimate of the intervention or treatment effect reported? So the confidence intervals are really important to be reported, and the reader should be able to interpret the results according to the precision of the results, according to the confidence intervals that have been provided. So they should be provided. In scientific writing, we say that these confidence intervals and p-values should be also reported in the abstract. Do the benefits of the experimental intervention outweigh the harms and costs? This is also an important question. What was the size of the intervention or treatment effect? As Dr. Shamshiri had some examples of this. Were harms or unintended effects reported for each study group? was a cost effectiveness analysis undertaken. So we know that cost effectiveness analysis allows a comparison to be made between different interventions used in the care of the same condition or problem. Okay, so we can consider if there is any like cost effectiveness analysis or not. And in section D, which is the last section, will the results help locally? Can the results be applied to your local population or in your context? Are the study participants similar to the people in your care? Would any difference between your population and the study participants alter the outcome reported in the study? Are the outcomes important to your population? Are there any outcomes you would have wanted information on that have not been studied or reported? So this means that is there any specific or specific aspects or a specific outcome that has not been considered? If there is, then it may show that there are some problems with the validity of the study. Are there any limitations of the study that would affect your decision? And the last question is, would the experimental intervention provide greater value to the people in your care than any of the existing interventions? So we should consider what resources are needed to introduce this intervention, taking into account time, finances, skills. Maybe there is a good intervention, but we don't have time, we don't have finance for that, we don't have money for that, we don't have some infrastructure for that, we don't have any skill for that. So we should forget about that. We cannot use it in our clinical practice. Are you able to disinvest resources in one or more existing interventions in order to be able to reinvest in the new intervention or not? Specifically when you are in a decision-making situation and you should make some decisions that discontinue a routine procedure and allocating the resources for a new technique or procedure. So these questions relates to that kind of decision making. And then you will have a summary here. Okay, this was CASP, Critical Appraisal Program checklist for trial controlled trials. As you could see in the website, there were also a checklist by CASP for other kinds of trials. I just want to see that if no, it seems that there is some problems here regarding just I want to go back to the website to see if we could have now. Okay, let me just. Okay, let me just stop share and then try to see. Oh, it says still. I don't know what's the problem with the maybe my internet or maybe with the website of consort statement that we cannot see it. I try once more. Okay, I don't know what's the problem. It seems that it's not possible to see the website, but you can go there. And I just show you again the checklist in Word format. And you can go to the Concert website and you can see the examples. But as you can see here, there are many details here. So this 25 item checklist for reporting clinical trials. If you study this checklist, then you can have some also insight regarding critical appraisal of the randomized controlled trials. So I leave it to you. You can just go to the website and see how does it work, what information should be included when you want to report a randomized controlled trial. Okay, so I think.
Professor Khami, may I ask a question?
Yes, sure. I'm at the end of my presentation, so I'm ready to answer the questions if I can.
If somebody wants to do a RCT study, randomized control trial, does she or he should follow all the guidelines of this checklist in order that when he or she does the study can be published? Do you recommend?
Yes, because now I think maybe all of the journals now, when you want to report randomized controlled trials, they do want you to report according to the concert checklist. Yeah. And also because randomized controlled trials should be registered somewhere. For example, we have in Iran, Iranian Center for Registry of Clinical Trials. There are some other in other countries. So before starting your clinical trial, you should register your protocol there. And it is available and visible for all who wants to see it. When you and at that point, you also are required to have these concert elements in your protocol. So when you have the concert elements there, then you certainly will be able to report your findings and to publish your articles according to that checklist. As I know, the prestigious journals, most of the journals now, they want you to report your article and findings and prepare your papers according to that concert checklist.
Okay, and if the RCT that you want to do has been repeated before, can we find it in order to not repeat a study again?
When you do your literature search, if there is any other RCT like or the same as the one you want to do, then you will find it. You will find it. But because there are many centers for registry, so it's not possible to, I think it's not possible to search through all of the registry of clinical trials. So the best way is to do a good literature review, good literature search, and then you will find if there is any previously done RCT with your topic or not.
Thank you. Thank you for your advice about this question that I had. Do the audiences have any questions? I think all of you, it takes a long time. It was difficult to hear and dissolve in our body all these informations. It was really difficult. In each sessions, it's highly recommended that again, after the session is finished and when you are not tired, again, review the informations to resolve it in your mind, the information that has been released to you. Is there any question? There is a question for critical appraisal or of RCT article. Concert is good or CASP is better? It is a question from you, Professor Khami. Which one do you recommend for RCT appraisal article?
We should notice that Concert is for reporting RCT, an RCT. But the CASP checklist is for critically appraising. So there might be some differences. I told you that if you go through the consort checklist, you will have a good insight to, then you will be able to better critically appraise RCTs. But I think that the CASP and checklist like that is more practical, a more practical checklist, and you can practically use them. As you could see, for example, in the CASP checklist, there were some spaces, and you could even write some notes, and then according to all of this information, then you can decide if to accept the results or not.
Yeah. By this way, consort is for critical appraisal of an article, but CASP is a checklist to know what details we should follow.
Sorry, I could not. What did you say?
A CASP is a checklist
Yes.
to follow the details and items for an RCT, but consort is different. It's not a checklist. It's for the critical appraisal of an articles or the information that we have.
Vice versa. In fact, the consort checklist is more in detail. It has many details. But the CASP checklist just 11 questions.
Easier, it's most user friendly.
Yes.
Apparently, there is no other questions. So, do the audience let us to leave the program for today? Okay. Apparently, there is no questions. I wish you a nice. It depends on the time and which country you are. Wish you a good night. Wish you a good day. Wish you a good evening. Every country that you are, best wishes for you. I wish all of you are in complete health and safety during this COVID-19 pandemic condition. Take care. I hope we can see you again for the three more sessions we have. 2 more sessions we have. We're waiting for you for, pardon?
2 more sessions.
2 more sessions. I hope we can see you for the next Wednesday, and wish you the best. Have a nice time. Take care, and bye-bye, everybody.
Thank you for your coordination. It was really helpful. And then in the next session, we will go again deeply through these both the randomized control trials and also systematic reviews. So stay with us for the next session and next presentations, plus to our international speakers. And I just want to say goodbye to all. But I think the final photo, we should have it now. So if possible for everyone, it's possible to.
Yeah, I want a final photo with a mask. It could be a memory of during the pandemic condition with the mask.
Okay. So just waiting for those who can open their camera.
So from different countries, now I can see your faces. I wish all the guys the best in complete health and safety. It's fine to see the face of the participant. It's great. Hello, Dr. Shahriz Samad. I have not seen you for a long time. Dr. Azadeh Fartash and all the other audience and guys from different countries. Now we are in a friendly virtual program. I wish and I hope to see you, not virtually, in reality, in our country, in our home country, in Tehran University. I hope in the near future, after pandemic condition resolve, we can settle down and program that you kindly participate in this program. We can see you face by face. Wish the best and for good future. Was the photo taken or can we leave?
Yes, I take a lot of photos.
Really, a lot of photo. So one of them will be placed in the website and you can see it. Best wishes for all, guys. Bye for now.
Thank you. Bye.
Bye, Professor Khami. Bye, Professor Shamshiri, and all, guys.